Good afternoon, ladies and gentlemen, and thank you for joining us at this Padova Pancreas Club, which is also this month an international edition with a stellar faculty right from UPMC, United States. I have the big honor and the personal pleasure to have with us tonight Professor Aatur Singhi from the University of Pittsburgh Medical Center and Department of Pathology to talk to us about molecular testing and pancreatic cysts. So something that has been already debated, but he is definitely the right person to talk to and debate about this very intriguing topic because I'm sure that all of you are aware of probably one of the most impactful and important papers that have been published in the literature so far on this topic. And honestly, Atur, I have to confess you that most of my presentation has been, let's say, significantly changed, or better say, destroyed by the evidence that you're adding. Because, at the end, I usually say that we are striving for new tests to define how to, go to surgery on a timely manner, and who knows when this is happening. Well, finally someone is doing the right thing. And so I'm very happy to introduce to everyone here Aatur Singhi from UPMC for the topic integrating molecular testing to evaluation of pancreatic cyst. Once again, Aatur, thank you so much for being virtually with us tonight.
Oh, thank you, Giovanni. And as Giovanni mentioned, I'd really like to take the time, the next 30 minutes or so, to talk a little about integrating molecular testing to the evaluation of pancreatic cysts. But as I had talked before with Giovanni, was the fact that integrating molecular testing these days is honestly it's becoming secondhand for a pathologist like myself to use molecular testing for various issues that we have actually dealt with at University of Pittsburgh Medical Center to help pathologists. And that's actually the nidus of where we started and what we're trying to achieve. And that's something I'll discuss in the next 30 minutes is, one of the issues that we deal with pancreatic cysts is it really comes down to the pathologists where we're supposed to make a diagnosis. And that was really what prompted molecular testing of pancreatic cyst fluid at University of Pittsburgh was just to make it easier for pathologists and then specifically for patients at the University of Pittsburgh. But then it started to take off. And it's been kind of an interesting ride for honestly the last 8 years or so. But today I'll talk a little about pancreatic cysts, really reviewing where we're at with pancreatic cysts, some of Giovanni's work, obviously, going really to the molecular methods that we're evaluating and how we kind of came to that. Going from a single center study, observational analysis, multi-center studies, and then now where we're at now, where we've actually started an international study and then discuss some ongoing efforts at the NCI, evolving technologies that we're starting to employ here at the University of Pittsburgh, which will then release outward to other sites over the next few years. And so I think it's always nice to start a little with a case study. And to be honest, Giovanni, I kind of put this together with you in mind. And this is a patient back in 2008 that was a 60-year-old male presenting with an incidental cyst after a really workup of chest pain. The cyst was only 1.6 centimeters located in the pancreatic body, and an EOS was consistent with an IPMN. Unfortunately, cytology wasn't very helpful, and I have to admit, very often when it comes to pancreatic cysts, especially FNAs of a pancreatic cyst, cytology isn't all that helpful, other than the fact that maybe it might say mucin in the background or atypical cells or glandular epithelium. Maybe it's consistent with a cyst itself, that being an epithelial line cyst, or maybe it's just gastrointestinal tract contamination. CA testing was done and it wasn't elevated. It was only 4.9 nanograms per mil. Molecular testing, and this is again before my time, and I will tell you that when it comes to the University of Pittsburgh, we had initially the PANDA study and other studies overall that had started looking at molecular testing and really old formats when it comes to molecular testing. When we were doing Sanger sequencing, which most institutions don't do anymore, we're all doing next generation sequencing. But back in the day, and that being 2008, they were quantifying DNA from cyst fluid. They were looking at mutations like KRAS just at codons 12 and 13. Now we know that KRAS can have mutations in multiple codons. And what they identified was just loss of heterozygosity at chromosome 1p36. I'll be very honest with you, at the time in 2008, we hardly knew anything about pancreatic cysts, especially when it comes to molecular testing. Wasn't even sure how we were dealing with this molecular panel. The panel itself, when I got here in 2012, was no longer in existence, and we started anew. But I will say that it was pretty much indeterminate type of pancreatic cyst overall, and again, 1.6 centimeters. Again, this was back in 2008, 60-year-old male. In retrospect, the gastroenterologist was able to pull out the CT scans going back to 2004, so 4 years earlier, and they did see that in retrospect that cyst was there, and it was about 1.6 centimeters stable. Patient had follow-up imaging then in 2009, 2011, and showed the cyst remained honestly unchanged. And I think that these are the type of cysts or these the type of patients that we see when it comes to pancreatic cysts, often incidentally identified. And, unfortunately, we're all trying to determine what to do with the cyst if we don't know exactly what we're dealing with. Is it an IPMN? Should we continue following an IPMN if the patient had identified that, or they have identified that cyst since 2004, and now it being 2011, should we continue to be 10 years follow-up based on Giovanni's data, especially being a 60-year-old now at this point in time in 2008? Should we stop following it with there's no concerning findings? And to be honest, it all comes down to the patient and their anxiety getting repeat imaging and how long they're going to continue getting repeat imaging for the rest of their life, or to stop and move on. And so what we're dealing with when it comes to pancreatic cysts, and honestly, when it comes to why we're evaluating pancreatic cysts, is that it's really a numbers game, because it's all about really pancreatic cancer and the risk of developing pancreatic cancer when it comes to pancreatic cysts. And I think that we all know a lot about pancreatic cancer. We know how bad it is. It's currently in the United States, it's the third leading cause of cancer deaths in the US. It ranks first in mortality rate amongst all the major cancers in the United States. Sadly, 80% of patients die within the first year of diagnosis, and 89% of patients die within 5 years of being diagnosed. In the United States, current census states that about 60,000 Americans are diagnosed with pancreatic cancer each year, and probably about the same number of patients are dying from pancreatic cancer each year. And sadly, I would say that if I were to tell you a few years ago, we had 0 early detection methodologies. I think that's changed a little now with new screening protocols, but obviously not for the general population. And then more for pancreatic cysts in that high-risk populations. I think that there is now modalities that we can use to help in developing early detection methodologies and hopefully successful treatment options in the near future. But despite the dire statistics that we understand, we do know a lot about pancreatic cancer from the last decade. We know that pancreatic cancer, just like other neoplasms, is fundamentally a genetic disease. It arises from the normal pancreatic ducts in the pancreas itself, and it goes through a multi-step progression model where it requires genomic alterations such as KRAS. And that multi-step progression model takes time. It takes over probably a period of years to develop into what we know as pancreatic cancer, going past the basement membrane of the normal ducts themselves and invading into the surrounding parenchyma. And that itself is a multi-step progression that involves not only genetic alterations, but epigenetic, biochemical alterations, and eventually giving pancreatic cancer its aggressive and destructive properties. In addition, and although a minority, we know that about 15% of pancreatic cancers are thought to arise from cystic precursor neoplasms, such as intraductal papillary mucinous neoplasms, or IPMNs, and mucinous cystic neoplasms, or MCNs. Collectively, IPMNs and MCNs are known as mucinous pancreatic cysts and are often identified by standard radiographic imaging, such as CT or MRI. Thus, in theory, they're actually amenable to early detection methodologies because we often identify them incidentally. We see them by radiology, and now you have a modality to continue following them for at least the course of the disease process. In other words, if you take the 60,000 Americans diagnosed with pancreatic cancer each year, for again 15% or 9,000 patients, and that's not a small number, not insignificant at all, you have that ability of potentially preventing pancreatic cancer in a significant number of patients, a significant population overall, at least in the United States. The problem is, though, is that amongst those 9,000 Americans that have pancreatic cancer arising out of pancreatic cysts, is that the fact that pancreatic cysts are extremely common, at least in the United States. Based on CT and MRI imaging, we're talking about at least 10% of individuals that have a pancreatic cyst when they're over the age of 50. And then that increases as they go to 60 to 70 years old overall. In fact, it's estimated that about 12 million Americans every year have a pancreatic cyst in the population, such that it becomes very challenging to determine which cysts are the ones that will progress into pancreatic cancer. The other issue when it comes to pancreatic cysts is that it's not just mucinous cysts that we have to deal with. We have to deal with a broad variety of different types of cysts that have been described in, honestly, the pathology literature. And you can blame the pathologists overall for identifying all kinds of subtypes of pancreatic cysts. Although I like to blame the surgeons, Giovanni, because I think that in the end of the day, it's you guys that are taking out all these cysts and then we describing all these different types of cysts that are there, many of which unfortunately mimic a mucinous cyst, and that being an IPMN. And so the reality is what we're all trying to identify, first of all, and that's the first step, is can we distinguish a mucinous cyst from a non-mucinous cyst in the preoperative setting? And that's a really important aspect, mostly actually for the pathologists, so that we can give that information to both our gastroenterologists and our surgical colleagues. The problem, however, is even if we do identify mucinous versus non-mucinous cysts, we know that mucinous cysts are extremely common, especially IPMNs. Probably IPMNs encompass over 50% of all pancreatic cysts, at least in the United States, and such that even if we did identify every mucinous cyst, and let's say we sent them all for surgical resection, whether that be robotic surgery or not, we could be putting those patients at significant harm if we're going to go resect 6 million IPMNs every year. And so what we're really looking for is predicting which of those 6 million mucinous cysts or 12 million or 13 million pancreatic cysts every year are going to transform into pancreatic cancer, and that being really a needle in a haystack problem overall. And so how do we deal with pancreatic cysts? And I'm probably preaching to the choir, so I apologize if this is a lot of review, but it really takes a multidisciplinary approach. It involves clinical presentation, cross-sectional imaging, advanced ultrasound, that being endoscopic ultrasound. And then a key component, at least in my opinion, is pancreatic cyst evaluation, is the aspiration of pancreatic cyst fluid. And that's for biomarkers, ancillary studies that are often done, and that includes CEA or carcinoembryonic antigen, glucose, and cytologic evaluation. CEA, glucose, as well as amylase are important markers of different types of mucinous cysts overall, and cytology can aid in the detection, and sometimes even in some literature, you'll look at it, subtyping of different pancreatic cysts, but most importantly, detection of malignant cells. Now, it was shown in a recent meta-analysis for the more recent Kyoto guidelines, all three modalities, CEA, glucose, cytology, have their limitations in both sensitivity and specificity. Utilizing a cutoff of 192 nanograms per mil when it comes to CEA evaluation is unfortunately associated with a 58% sensitivity and an 87% specificity for mucinous cysts, which once again could be either an IPMN or MCN, so it doesn't really help you in distinguishing the type of mucinous cysts you're dealing with, nor is it useful when it comes to distinguishing the presence or absence of a malignancy or high-grade dysplasia. Similarly, glucose with a cutoff of less than 50, and in some studies even less than 10, has shown at least improved sensitivity for mucinous cysts. That is also has a high specificity comparable to CEA testing. The problem, however, is it's not a perfect assay overall. It doesn't truly achieve 100% sensitivity and 100% specificity. I have to admit that there's probably never going to be a perfect test, but the problem when it comes to glucose testing is it still doesn't get you the crux of the problem, is identifying those mucinous cysts that will progress or at least are at present a malignant process or high-grade dysplasia overall. Nevertheless, amongst the main pancreatic cysts themselves, when it comes to IPMNs down to pseudocysts, we do know a lot of variable and cofactors that we can use to help make a diagnosis overall, where we can combine clinical metadata such as gender, like in MCNs, when it occurs typically in middle-aged females, it involves the body or tail of the pancreas. Fluid characteristics. Is it viscous? Is the string sign itself positive, consistent with thick, tenacious mucin in an IPMN or an MCN? Or ancillary chemistry tests like CEA and glucose, as I mentioned, or even amylase themselves. And then more importantly for me as a pathologist, cytology, where you can look at the cyst fluid itself and hopefully make some sort of diagnosis, whether even the background of the cyst fluid itself, is it thick, is it mucin, is it present there, or are there cells present, and are they consistent with high-grade dysplasia or cancer in general. Problem, however, is when it comes to all of these aspects, especially cytopathology, it often has scant to no cellularity. I deal with gastrointestinal tract contamination all the time because a needle has to go through the GI tract to get to the pancreas. And then even there are inaccuracies with CEA and glucose testing. In fact, I can tell you for a fact that the CEA analyzer and glucose analyzers that I have here at the University of Pittsburgh are very different from those in Italy, Padova. And so how do we basically come to a commonality when it comes to testing strategies and modalities? And where do we draw the cutoffs overall? And so what we're dealing with are guidelines. That's going to be the next aspect where we try to integrate really consensus and evidence-based guidelines for multiple factors when it comes to patient age, stratification of cyst size, how long has a cyst been identified. The unfortunate problem with all of these guidelines and trying to integrate honestly, multiple disciplines overall is that they still suffer from low quality of evidence and unfortunately because of that demonstrate poor diagnostic performance. They're very retrospective. They can be biased towards surgical series. They don't take the patient as a whole in a personalized approach into account. And so where we're all after are better markers or better biomarkers. And when it comes to biomarkers, I can guarantee you if you do a PubMed search today versus tomorrow, you'll find a million biomarkers, literally 10 to 15 added every day in PubMed, such that it becomes to the point where I have a pathologist that looks to me all the time and comes back to me saying, gosh, there's just too many biomarkers to deal with. Is really the juice worth the squeeze? And that being pancreatic juice and FNAing the juice itself. Is it really worth keep looking for more and more biomarkers? And amongst those biomarkers, are any of them truly ready for prime time? And that being clinical utility and clinical use overall. And I'd say that the vast majority of biomarkers still need a lot of work. They're not ready for prime time. They're not able to be established in a clinical lab in a cost-effective manner. But that being said, I do think that in the last few years, we've seen some exciting research, and honestly, from both Italy and Johns Hopkins, where we've seen some amazing work in DNA-based testing, and that being a promising biomarker, not just for pancreatic cyst evaluation, but for other types of neoplasms overall, and other organ types in addition. And I think that's where we've seen a lot of gain and a lot of advancements and the ability to do this in a quick, effective manner and honestly in a pathology lab that could be really distributed to multiple areas throughout the world. For instance, when we go back to our table of major pancreatic cysts, amongst all the pancreatic cysts that I've mentioned, what we know is that they all have very distinct molecular profiles. For example, IPMNs were discovered to harbor mutations in KRAS and GNAS. In contrast, serous adenomas, which can mimic IPMNs, are characterized by VHL alterations. And then non-neoplastic cysts are devoid of any of the above mutations overall. In fact, based on these findings, one could create really a very specific molecular panel that could be used to assay preoperative pancreatic cyst fluid to aid in the development or the diagnosis of a pancreatic cyst, such that we could actually even go further with that. If we knew the type of cyst we're dealing with, can we then look at markers of progression? And from molecular testing with whole exome sequencing, whole genome sequencing, we are already there. In fact, despite the refinements of the cyst guidelines that have been developed based on low quality of evidence, we actually have a lot of evidence on the molecular background and the progression model of a low-grade IPMN to a high-grade IPMN to adenocarcinoma, such that we know genomic alterations like P53, SMAD4, the mTOR pathway that includes PIK3CA-PTEN. These are all alterations that have been identified to be associated with development of high-grade dysplasia and progression or transformation into adenocarcinoma. That we could also be added to the list, such that we now have honestly a very unique and powerful panel for molecular testing of pancreatic cyst fluid to evaluate patients with pancreatic cysts and maybe help stratify them for eventual treatment or management overall, that being surveillance, continued surveillance, or going to surgical resection. And so in recent years, and this is not just us, but in several academic institutions and even commercial entities, have really focused on the utility of DNA-based testing of the evaluation of pancreatic cyst fluid. And I would say that honestly, several limitations have occurred that we've identified is that we're all doing something very different. We have different assays, different sensitivities, different specificities when it comes to molecular testing. It's very similar to what the issues that we're dealing with CEA and glucose testing, and such that, honestly, it's very hard to distinguish between what is important when it comes to molecular testing of pancreatic cyst fluid and what is the real performance of this in honestly patients overall. Most of the studies to date have been very retrospective, single institutional studies, and really haven't accurately looked at patients as a whole in a large population of patients, and then patients that haven't even gone to surgical resection. And so that really culminated to a study that we started a few years ago, actually maybe now 4 or 5 years ago, that was really a multi-institutional observational study to evaluate a panel that we created here at the University of Pittsburgh Medical Center called Pancreaseq. At the time, it was a 22 gene panel, included many of the genomic alterations that are associated with pancreatic cysts, as well as honestly genes that are involved in pancreatic ductal adenocarcinoma that we really wanted to use as a discovery-based approach to understand what the genomic profiles are of a large compendium of patients with pancreatic cysts. And that included patients that we honestly opened up to just specifically the United States, that included over 31 institutions and tested over 1,800 patients. Over 1,900 really specimens or pancreatic cyst fluid specimens overall were evaluated. And then within that observational time period, we then waited for surgical outcome for follow-up to occur for a lot of those patients. Again, this was a very observational study. We didn't ask the gastroenterologist or the surgeons to act on the molecular testing. It was really up to them. But what we did was we actually asked them to send it to us in real time. So as an FNA was done, next day it was sent to the University of Pittsburgh for basically molecular testing in a prospective fashion, turnaround time of 7 days, such that we gave a report to the gastroenterologist and surgeon and even the patient of what the molecular profile of their pancreatic cyst was. And what we found was that sensitivity and specificity of Pancreaseq, looking for various genomic alterations when it comes to mucinous cysts, yielded a 90% sensitivity and a 100% specificity for the mucinous cysts. That was superior for CEA testing at each of those institutions. CEA was not centralized. It was literally done at those institutions overall. So was cytopathology. And for advanced neoplasia, that being high-grade dysplasia and cancer kind of together, Pancreaseq achieved 89% sensitivity and 98% specificity. Wasn't perfect, and honestly, no test will ever be perfect. But we are getting to the point where we can start combining that with different data points and where we can help stratify patients and hopefully stratify them based not just on molecular testing, but other cofactors, maybe cyst size, the patient's age, family history, and that's things that we're looking into now. But we did learn a lot about the molecular profiles of pancreatic cysts. And it's not just about KRAS or GNAS when it comes to IPMNs or mucinous cysts. One of the key findings that we found when we tested actually over 1,000 different mucinous cysts was that we found a prevalence of a BRAF mutation. BRAF mutations are known to be present in colon cancers, but they can also be present in pancreatic cysts and even pancreatic ductal adenocarcinomas. But it's not your conventional BRAF V600E mutation that's often found in colon cancers, but it's really what we call non-V600E mutations. It's what we call class 2 and class 3 BRAF alterations that also satisfies as another marker, a third marker of mucinous cysts, specifically that being IPMNs and very specific for IPMNs. In addition, in fact, we find that with a lot of patients that actually had main duct involvement with these BRAF IPMN alterations. And so it's maybe potentially even another marker for extension or mixed type IPMNs, eventual development of mixed type IPMNs to have that BRAF alteration overall. One of the things we also did was we tried to look comparatively with whole transcriptome sequencing. At the time of this study, we were just learning how to do whole transcriptome sequencing. And what we were decided to do was compare BRAF mutant IPMNs with KRAS, or traditional KRAS mutant IPMNs. And honestly, they were exactly the same when it comes to RNA profiles. Also supporting the fact that it's probably just an IPMN and it's utilizing BRAF instead of KRAS. probably not giving too much of a factor itself, other than the fact that we found a lot of these BRAF mutations in mixed main branch duct IPMNs or main duct IPMNs overall. Other things, what we learned was that serous cystadenomas are not just characterized by VHL alterations, as I mentioned. Interesting enough, we came across a lot of large serous cystadenomas, and I'm sure you've seen the same thing, Giovanni, where we have all these large serous cystadenomas, maybe on the order of 3 or 4 centimeters. Sometimes they wrap around normal structures like the pancreatic duct, the biliary system overall, causing compression, and sometimes these are the patients that come to presentation. In addition, some of these larger serous adenomas grow fast. Over a course of a couple of years, they can increase in size, which makes you concerned, is it really a serous adenoma? And what we found is it's not just about the VHL alteration that's associated with these large size growth, but it's also the presence of other alterations that serous adenomas can acquire on top of VHL. And that, interestingly enough, includes p53 alterations and TERT promoter mutations. That could be a new sign of why they're growing and why they're becoming large. They're not transforming into what we used to call serous cyst adenocarcinomas, but they're just large serous adenomas that tend to wrap around structures and grow over time, and something that we're now utilizing to help monitor serous cyst adenomas, because those patients could very well present with symptoms later in life. But we also found that there are other alterations that are specific markers, not just p53 and SMAD4, but markers of high-grade dysplasia and cancer. And those can actually be... Sorry. And so these fusion genes that we identified at the DNA level include PRKACA, PRKACB, FGFR2, NRG1, RET. And interesting enough, all of these fusion genes were always associated with either high-grade dysplasia or cancer. In fact, one pair of fusion genes, PRKACA and B, were associated with what we call interductal oncocytic papillary neoplasms, which universally harbor high-grade dysplasia, and about 30% of patients will have developed at least pancreatic ductal adenocarcinoma. So honestly, these fusion genes were just another marker of high-grade dysplasia and cancer itself. And then lastly, one of the other things we identified from this study itself was that it's not just the presence or an absence of a mutation, but we have the ability with next generation sequencing, which we didn't have before with Sanger, to quantify that mutation in the patient's pancreatic cyst fluid, especially when it comes to other alterations. So kind of taking a step back, as I mentioned before, KRAS, GNAS, and BRAF alterations are often associated with mucinous cysts, and that being GNAS and BRAF, very specific for IPMNs. And when you have just those mutations like KRAS, GNAS, or BRAF, like GNAS in this case, and GNAS alone, it's going to be consistent with low-grade IPMN. However, when you acquire another alteration, those late genomic alterations like PIK3CA or SMAD4, P53, and it has an equivalent allele frequency, meaning that it's the same amount of that mutation, that correlates with high-grade dysplasia or cancer. But we found a subset of patients where the PIK3CA or P53 alteration or SMAD4 was at a very low level in comparison to GNAS, meaning you had a quantified amount of GNAS at 30%, but you only had 3% of PIK3CA mutation. And what those mutation or that profile itself correlated with was a low-grade IPMN. Now, at one point in time, we thought, oh, this is horrible. Basically, these markers aren't specific at all. But it gave us an idea that likely these are the patients that we need to monitor closely, because these are the patients that could develop into high-grade dysplasia or more likely develop into high-grade dysplasia and cancer. And in fact, we had a few patients with low-level P53s that over the course of the study and the observational period itself did develop an adenocarcinoma over time, where that P53 on repeat was low level first, and then eventually attained the same level as the KRAS mutation, and unfortunately developed either high-grade dysplasia or cancer, like in this patient overall. In fact, what we believe now is that we could help stratify patients even further, identifying KRAS, let's say a combination with SMAD4. Those patients, obviously, in our opinion, should go to surgery. But then if they have a low-level alteration, as far as quantifying that mutation in SMAD4 or P53 with respect to KRAS, maybe those patients should undergo really close surveillance, because they are the ones that are more likely to eventually develop pancreatic cancer or high-grade dysplasia. while those that don't have or are absent in those alterations, or have a VHL or negative for alterations overall, could actually undergo long-term surveillance depending on other factors overall. And so how do we culminate all of these alterations that we've identified over the years? Well, we've also continued learning about the molecular profile of pancreatic cysts over the years since the initiation of Pancreaseq back actually in 2018. And so now it comes time to the point where we have to modernize the assay, integrate what we understand from our observational analysis, what we understand from other investigators at Hopkins, at Italy itself, what they've learned about pancreatic cysts. And so we recently created a new panel called Pancreaseq Genomic Classifier that not only goes really DNA-based testing, but goes beyond that to now RNA-based testing. In fact, Pancreaseq GC is what we call it, includes 75 genes at the DNA level, and then 180 genes at the RNA level. And I think that this will be the next step in our understanding of pancreatic cysts, where we're honestly going through the same trials and tribulations we did with Pancreaseq in the 22 gene panel between 2018 and 2022, where we're now doing an international study with the 75 gene panel with 180 positive fusions at 47 institutions across the United States, Canada, Mexico, a few places in Europe, as well as a few cases in the Middle East that are sending specimens to us. Currently, we have about in the last 2 years, 6,500 patients accrued, and we are starting to collect follow-up on those patients, seeing who went to surgery, who didn't, who are the patients that have, at least maybe we failed. I'm looking really closely at patients where we just didn't get things to work out, where we missed, or did we overcall any of the patients, especially at the RNA level. And I think this will be very eye-opening as we continue to understand and start to get really granular with patients with such a large cohort. We can start getting into race, ethnic diversity, especially being in an international cohort overall, and then other aspects in addition, that being size, location, et cetera, and age. So let's kind of go back to the same patient that I started with. And again, if I just want to remind everybody, this was a 60-year-old male with essentially a stable 1.6 centimeter presumed IPMN based on imaging that again was stable between 2004 and 2011. Clinically was an IPMN. We couldn't really prove it with CEA testing at the time. Molecular testing was very antiquated, and honestly, I don't know what to do with it. Cytology was sadly, not very helpful. Overall, an indeterminate cyst, but based on imaging, I think most people would consider it an IPMN. Now, really, to make a long story short, in 2011, the patient honestly chose on his own not to continue surveillance and just to end it all. Wasn't feeling interested. Nothing was changing. He felt on his own that nothing should happen. He's not at risk for developing anything with a small pancreatic cyst. Now, one of the things that we do, at least at the University of Pittsburgh, is we have been actively retrospectively evaluating patients that we've done prior molecular testing on. We feel that we're responsible for the molecular results, even back in 2008. And if we're going to modify a test that we offered even in 2008 and now we offer now, why should a patient have to be subjected to an old test and not be at least provided a new test free of charge? And so one of the things that we've been doing is retrospectively going backwards and evaluating cyst specimens that we have in our bank, and that being our clinical bank, where there may be sufficient nucleic acids. And interesting enough, we subjected Pancreaseq GC testing to this patient and that 2008 specimen, which identified actually a PRKACA fusion gene. PRKACA fusion genes, again, are associated with intraductal oncocytic papillary neoplasms. And IOPNs, again, universally harbor high-grade dysplasia, and 30% of patients will have an associated adenocarcinoma. So with that data, we were obligated to tell the patient's gastroenterologist. That gastroenterologist then called the patient to come back for surveillance imaging, really encouraging him to see, let's see what's going on with that pancreatic cyst. And interesting enough, in 2024, and that's literally just a few months ago, that cyst now is no longer 1.6 centimeters as it was in 2008 or 2004, and it is now in 2024, 6 centimeters. Again, knowing the data, excuse me, about IOPNs universally harboring high-grade dysplasia and 30% having an associated cancer, and now knowing that the patient has a 6 centimeter cyst is asymptomatic, although asymptomatic, they elected to resect the patient, and the patient underwent a distal pancreatectomy robotically that revealed, honestly, a 6 centimeter IOPN. very prominent nodularity, as most IOPNs have. It was involving the mixed main and branch ducts. And it was oncocytic, as an IOPN should be, and it's been well known now. We've done over about 100 IOPNs in characterizing their molecular profile across, honestly, the world. And they consistently have PRKACA or PRKACB fusion. So we feel very confident when we identify these fusions that they are consistent with an IOPN. Now, as I mentioned before, IOPNs universally have high-grade dysplasia, and this one did. Thankfully, no invasive adenocarcinoma. But to recap, again, a patient that in 2004 had a 1.6 centimeter cyst. We identified a PRKACA fusion gene in 2024 that led to a resection of a 6 centimeter cyst. Literally 20 years of theoretically, we could have honestly changed the course of management if we knew back in 2004 that it had a PRKACA fusion gene. Could we have intervened? Could we have done a smaller surgical resection at that time? I'm not sure. I'm not a surgeon, nor a radiologist or gastroenterologist, but I think it's very provocative to now think about, can we actually predict what will happen to some of these patients over time, knowing their molecular profiles? So in summary, I hope I've actually impressed upon everyone kind of some of the things that you can do with next generation sequencing, where we're at currently, where we're going in the future. In my personal opinion, I think it can improve the evaluation of pancreatic cysts. And in our experience, at least at the University of Pittsburgh, that's what we found. And that, when it comes to molecular alterations, pancreatic cysts are extremely heterogeneous, as that would be expected with so many different types of pancreatic cysts, where we now know we have very good markers overall that, in my opinion, again, are superior to CEA and glucose testing, and that being KRAS, GNAS, and now BRAF alterations overall, very highly sensitive, specific for mucinous cysts. Alterations in your high-risk genes include P53, SMAD4. A new one on the block that I really haven't mentioned is CTNNB1 or beta-catenin, as well as some of the mTOR genes. I think it's very imperative to not just look for the presence or absence of a mutation, but the amount of that mutation with respect to the initiating factors like KRAS and GNAS and BRAF versus the high-grade mutations overall. And I think this makes sense. This is giving you an idea of a progression model overall and what's going on with these patients. And you can use that information to help prognosticate your patient. We now know that there are alterations, specifically fusion genes, that are new markers of high risk, really that being high-grade dysplasia or adenocarcinoma. And then serous adenomas, it's not just that they're benign and you find a VHL and you can let them go, but knowing that they might have a P53 or TERT promoter mutation on top of that, that could actually tell you a little more about what could happen to that serous adenoma in that patient's lifetime, especially if it's a 30-year-old female that's got a serous adenoma and a TERT promoter mutation. I can tell you for a fact that's going to grow over her lifetime. And she should be aware of that and not have to deal with the anxiety, but also understand that this could impinge on normal structures and maybe something that they should consider, maybe even to the point of intervention. But I think that there's a lot to do when it comes to pancreatic cysts as a whole. We still haven't really understood, like, who do we test? What types of cysts should we test? Should we test anything that's maybe 1.6 centimeters, like this patient that we talked about, or larger? How often should we test? Some of these patients were identifying pancreatic cysts at a very early age, at the age of 50, and they've got a long lifetime ahead of them. How long do we continue to survey, and how often should we repeat test? And what does that surveillance look like? Should we end surveillance based on age, size, stability? Should we continue surveillance based on certain mutational patterns? How do we even integrate molecular testing to current and future guidelines like we're talking about when it comes to global cyst guidelines? And then what about other applications? We're starting to see that our gastroenterology and surgical colleagues are deciding to use Pancreaseq for many different modalities and different questions to answer. Honestly, it's kind of funny to see it being used on different specimen types. They're using it on aspiration of the main pancreatic duct, aspiration of duodenal juice now. They're using on neuroendocrine tumors to help make a diagnosis. They're also even using it on solid lesions because sometimes pathology just can't get to the diagnosis. And so it's very interesting to see where we're going. I would see where we're going, though, is we've maxed out at the DNA level, and now we're going to enter really the RNA age. I think a lot of you have heard about spatial transcriptomics or transcriptomics in general. I think that is the next stage, but in this day and age, you have to start somewhere. and that's going to be whole transcriptome sequencing. And at the University of Pittsburgh, and what we're working with a few partnering institutions, we started doing just that. We've been able to isolate RNA and stabilize RNA when it comes from the FNA needle, such that we can do whole transcriptome sequencing. And to date, we've done actually over 400 patients with whole transcriptome sequencing. That probably be the data that we'll use for the next version of Pancreaseq overall. But I think it's a very exciting time where honestly, the cost of everything when it comes to next generation sequencing, DNA and RNA, they've actually stayed exactly the same for us, even though we keep increasing the amount of genes because the reagents keep decreasing overall and the throughput keeps increasing. So the cost of Pancreaseq hasn't changed for the last decade, and yet we've gone from honestly initially 7 genes to 75 plus 180 plus now whole transcriptome testing. So I think it's a very exciting time, in my opinion. But honestly, you can't do this by yourself. You need to have a group of people that are not just at the University of Pittsburgh. You have to be everywhere. Honestly, Hopkins, Texas, University of the Texas System itself, that includes MD Anderson and California sites as well. Honestly, throughout the United States and now the world, we're really indebted to a lot of the interest that people have, and honestly, the curiosity that they have and interest in general collaborating. And that has really made and driven the study. It's not the University of Pittsburgh, it's not myself nor our molecular lab, which I love to death, but it's really the people that have taken a really an engaged process of looking and delving deeper into their patients, going past just imaging and conventional imaging and symptomatic symptoms overall and presentation, but really going to the next level. And then we're also indebted to honestly generous funding from the National Pancreas Foundation, PanCAN, Sky Foundation, Department of Defense of the United States, as well as the National Cancer Institute. I'll leave you with these words about that proverbial needle in the haystack. I think that there's a lot of other needles we need to look for, and I think there's going to be a lot more uses when it comes to molecular testing, especially as the costs of it start to decrease. So with that, I'm happy to answer any questions if there are any.
That's fantastic, Aatur, really. You know, I, again, I usually end my talk on the same topic exactly from your, I would say, introduction. And so this is to me the natural sort of like even philosophical, continuation of what I think the direction is indeed. So again, this is not an Italian flattering to you because you know what I think about this way of thinking, this critical thinking, and you're absolutely right. I mean, most of the evidence we have comes from the surgical series that basically told us back in the day we are operating way too much, and that's basically how you guys in the path uh, from the path department had so many way to define entities. So let's now try to play the devil's advocate because obviously, I mean, I completely and totally understand your point, and I totally agree with this view of IPMN. I love the numbers you provided. It's truly, an epidemiological boom, and we cannot really consider any liberal policies on this entity anymore, not even in terms of surgery, but also on follow-up. I would like also you to comment on that as well. But first of all, again, let me play the devil's advocate and go back to the case that you showed. I loved it. It really pictures the issues that we all face. But you are teaching us how this genetic alteration, they tend to sum up and to occur at some point in the evolution of this cyst. So, are we really sure? And again, I'm gonna play with you a little bit. That at that time, back in the day, some 20 years ago, that genetic alteration was already there. Or is it something that took place at some point, making the Pancreaseq, let's say, less efficient in that early stage? Because if it's actually that useful, then you have the potential, indication to sample every cyst. And that would lead to my second question. Is it really worth it to do so? Or are we going to have more acute pancreatitis for all the needles we're sticking into small, trivial, I like to call them, cysts in the pancreas? But not too many questions. Let's start from this first provocative one, and then let's also ask other things to you.
No, that's a very good question. First of all, do we know that the PRKACA fusion is the initiating factor to form that cyst? The same being said, is KRAS or GNAS really the initiating factor? I think we know it's the earliest event that can occur that we know of, but is it really the start of everything overall? And so I think that is certainly a challenge to understand. I think that at the moment we believe, based on our data and sequencing, and we've sequenced a lot of patients, but that's probably not enough. I mean, we've sequenced every surgical resection specimen that we've seen since 2019 so far, and we've done whole transcriptome on pretty much almost all of them as well. That we believe that the PRKACA fusion gene itself, as well as KRAS, are truly an initiating factor for IPMNs, looking at polyclonality, looking at multiple areas, multi-region testing that Laura Wood pioneered back in the day when she started looking at multiple clones of IPMNs. We were doing as well, but I think that without a doubt for us, based on our data, the PRKACA B fusion genes are an initiating factor. We tested the 2008 specimen. So we went back to the 2008 specimen. So we weren't really testing a 2024 specimen. And that's also a nice thing. The fact that the specimen is still stable, the nucleic acids are fine to go back to, means that also that that fusion gene probably is very real overall. It's not a mistake, and we know that the outcome was an IOPN as well. That fusion gene was there in 2008, so certainly I think that initiated it. Now you could argue that, well, if it's even though it's increasing in size, the patient is asymptomatic, it's 6 centimeters, it now involves the main and branch duct. You already know that nothing has happened yet. No one's gotten to a diagnosis of cancer. So why not leave it? Why not leave high-grade dysplasia in that patient? That patient now is 70 something years old, still has a really good life in front of him. Dealing with a distal pancreatectomy is fine for him, according to the surgeons. According to the surgeons, pathologists can't weigh in that. But I think that, certainly, I think this was maybe the right thing for that patient because you never know when it will transform into cancer. And we all know how bad pancreatic cancer is. Now, as far as who to test, that is honestly the problem that I cannot answer. I think that that is a really, really good question. And that's probably the first question that needs to be answered and one of the most important questions that need to be answered. I know, over the years, people have asked me, oh, we should do cost-effective analysis. That needs to be the first question. Is it cost-effective to do it? I would say that the cost now for me to do molecular testing and for what we're doing, if I went back to even to the 22 gene panel, that's honestly pennies, to be honest, based on our current charges. If you're going to do an FNA, you should send for molecular testing, in my personal opinion. If you're going to take any cyst fluid out with a needle, if that was any indication, whether it be for molecular testing or just to be able to understand what's going on in the cyst itself to send to a pathologist, you should also send it to a molecular pathologist. I don't see any reason why you wouldn't do molecular testing hand in hand with glucose testing or CEA testing. It's exactly the same type of test. It's just a little more unique. It's a little more boutique, but it's coming to the point where everybody has a molecular lab. I haven't seen many pathology departments anymore that don't have a molecular lab. Now, that doesn't mean that everyone should be doing molecular testing of pancreatic cyst fluid. It's not going to be cost effective if 1,000 institutions are doing their own molecular assay. It's going to cause a lot of confusion. Our thought process now, after going through this multiple times and even giving technology out to other institutions and understanding the trials and tribulations of doing it, it just didn't work out to the point where they're doing the same exact assay as us when we sent it out to another institution. To the point now where we're under the model of we are happy to test whoever wants to send it to us, and we'll work out the pricing in general. I think that one of the things that's been beneficial to us also is that every time we do a couple thousand here and there, it starts driving the price down because we buy in bulk. And Illumina, Thermo Fisher, they start discounting items because we're buying so much in reagents, such that it becomes extremely cost effective to do this test.
Right, right, right. I mean, again, I completely get your point and agree with you on this. So, are there any questions for Aatur? Otherwise, I have a list. Aha, I see raised hands from the West Coast, believe it or not. This is
Yeah.
an international Padova Pancreas Club. Aatur, can I introduce you to Dr. Tommaso Pollini? who's a surgeon scientist. So he combines all the knowledge of a surgeon trained in Italy, actually doing now research at UCSF US, one of the brightest mind on IPMN I've ever had the pleasure and honor to work with, and he's also one of my best friends. Tommaso.
Yeah,
Great.
exactly. Well, yeah, thank you. I mean, always too kind, but and also thank you, Dr. Singh. I mean, the presentation was just fantastic, and I agree with Giovanni when he was saying that just based on the total sum of the evidence you presented over the past few years, this test really looks like it's ready for prime time. But I had a few questions. I think one very small and practical is if you have a sense of what's the minimal volume cyst fluid that you need for the analysis, just for feasibility, I would say. And then I had another question, which is if you have a sense or any data of how your Pancreaseq test will translate on peripheral blood. I know it wouldn't be necessarily, one-to-one translation, and we don't, maybe there's even, but maybe you have experience on that, how that would go on the peripheral blood. And the last thing, even though like you asked us, there's a bunch of open questions on the end, and they're all very important. I would want to ask you if you have a sense of repeated test. I have no idea. Of course, I don't know, but maybe you have samples where you've done it. And that would be, of course, very useful in, what's the time, just even from a pathological standpoint, how much time does it take to progress and develop the mutations, plus with the amount, the metric data where you have the amount of mutation, that's really probably very interesting to integrate on the timeline of development of this lesion and progressive dysplasia from low grade to high grade invasive cancer. So yeah, but again, I mean, this is really amazing data, and it's very exciting to see it all together like that. Thank you.
Thank you. I mean, yeah, you're asking really good questions. The volume aspect is a very interesting question. We always thought, or originally when we started doing a lot of this back actually in 2012 when I got here, was that we thought that the volume of cyst fluid would be linearly correlative of the amount of nucleic acids. And that's not true. Some cysts make a lot of exfoliated epithelium, nucleic acids. They have a high turnover rate. Other cysts have been just sitting there for years, maybe a decade, and the DNA is hardly anything in there. And so even if you suck out, close to a milliliter of fluid, there could be like hardly any DNA or RNA present. The amount of volume truly needed, honestly, we just need a drop of the FNA volume itself. Now, sometimes an FNA is very thick. It's hard to get even something out of the needle itself. It's thick, tenacious. It's snot-like. It just doesn't come out of the needle itself. And so one of the things we've learned over the years is that, the pancreas itself also is a very harsh environment. And it's got trypsin, chymotrypsin, carboxypeptidase A. They're all degrading nucleic acids, proteins, RNA, everything. It's just a violent organ overall. And that's probably why it's causing pancreatitis every time you FNA it. And so we came to the point where we needed to create a workflow. And so what we do now is when we have a patient that is going to get an FNA, let's say in Mexico, we will ship out collection vials. And the collection vial contains a stabilization solution. The stabilization solution took us about 6 or 7 years to create. And it basically inactivates all your digestive enzymes in the pancreas itself, so that stabilizes the nucleic acids. It can also be used to rinse out a needle. So if that needle is really thick and stuck, the mucin is stuck in there and you can't even get anything out, you could suck up the stabilization buffer and it will use as a detergent and destroy some of that thick tenacity to it, and then allow the fluid to go from the needle into the stabilization buffer or the collection vial itself. Collection vial then has to be frozen or kept at least 4 degrees on ice, and then shipped out to the University of Pittsburgh at least within the next day, so that we can then isolate nucleic acids from there. Your question about when it comes to blood or peripheral blood tests is an interesting one, and it's something that we're constantly being asked about. Can we eventually get to the point of honestly surveillance at the blood level? Because we can't keep FNAing people repetitively, as you mentioned, and even in the last question. And I think that is the holy grail. I think that first, what will happen is that we set up and determine what type of cyst you have. And if it doesn't have any high risk markers or high grade, honestly, high grade or high risk genes themselves, then we need to establish a surveillance protocol, but it can't be repeat FNAs. Now, I will say that to the point where it can be repeat FNA when you see something else, maybe. But if it comes to the point of just repeating FNAs every year, every 2 years, that's just never going to happen, and it's not feasible. And so we do need to develop a blood-based test. I know one of my good friend at NGB, Carlos, loves to kind of push me saying that this is not where we need to be at Aatur. We need to be honestly at the blood-based level, and he's right. And so we don't have that test just yet. I know that there are a number of people, very prominent people at Hopkins, looking at that, and we were trying to work with them to develop something where we can do this as a blood-based assay, taking that technology eventually once we get it down right and putting it at the University of Pittsburgh and doing a number of patients in general, and that being honestly cyst-informed assays. Once we do the initial Pancreaseq and then develop a panel to help with monitoring disease. We're not there yet, but my hope is we will be there in the next year or so, where we start releasing an informed cyst assay overall. Now, when it comes to repeat testing, yes, we have seen a lot of patients with repeat testing, even patients that have had multiple versions of Pancreaseq. I would say we're down to probably at right now the 8th or 9th version of our molecular panel. We've gone through so many versions, tweaking one thing after another. When we see something doesn't work or something does work, we try to increase the sensitivity in one area, not another area. And so we have definitely seen a lot of patients that even have a molecular profile that changes, where at one point in time they had a KRAS, and then the next point in time they have a KRAS with a SMAD4. And they go to surgery and they have high-grade dysplasia everywhere. The question that Giovanni will ask me was there high-grade dysplasia there before, and we missed it on that molecular panel? And when we go back and we try to do apples to apples when it comes to molecular tests, we don't see that SMAD4 in that assay. So it could be a question of sampling. Maybe we didn't get a good sample the first time around, and the second time we did. My thought process is it's typically a gastroenterologist or surgeon initiating a repeat FNA. And they're probably initiating a repeat EUS because of something. And typically in those cases that progress on a molecular level, it's often those patients that have a size increase or the duct becomes dilated. So there's an imaging finding that's initiating a repeat EUS FNA. And if you're going to be there for another EUS FNA, I don't see any reason why you wouldn't send cyst fluid for molecular testing again to see if something has changed. And we do see things changed. We've had a number of patients that have just similarly had, KRAS or GNS at one point in time, and then 2 years later, something caused the gastroenterologist or surgeon to get a referral for another EUS FNA. And, it could have been the size, it could have been the patient, it could have been, something that's changed about the patient, and something has happened to that cyst. Now, we could either have gotten lucky or, something there that needs to be looked at more deeply. And that might be the indicator. It's not doing a blood taste test, but maybe something on the imaging level where we're doing serial imaging for certain patients. And if there's a change there, that would be the initiating factor for another EUS FNA and then cyst fluid analysis.
Thank you.
Thank you, Aatur. We have a question in the chat. Again, looking at the feasibility of centralization of sample cytology, you were mentioning that for molecular analysis at referral centers. So you basically touched this point. You want to briefly comment on that and then final.
So, I would love to test patients in Italy. And that's the key aspect. I would love to do that because we're really trying to learn as much as possible. I mean, right now we're working with Singapore. I have a good friend, Ludwig Bronsens at the Netherlands. I'm trying to figure out ways that we can somehow test their patients with Mark Veselick's group, obviously. We're trying to figure out ways to expedite that process because, we can't test patients just in the United States or the United States and Canada. It's not going to give you a full breadth of what pancreatic cysts are. And right now, we're working on the new WHO for pancreas pathology, and we're talking about cysts and IPMNs, IOPNs, ITPNs, all the different types of cysts. And, honestly, there's so much variability. If you think about Japan, you think about the United States. And we need to get a better understanding of that. And that's only going to happen is if we pull things together. I hate to say it, but it has to be one place or something where we have a same technology and we're evaluating the same way. And that has to be, in my personal opinion, centralization. And so I'm looking for very multiple ways to make it feasible. And so we will partner with anybody we can. We'll look for grant funding if we can do that. I'm happy to try to figure something out, but I think that's the next level. I really want to be able to do that. The University of Pittsburgh Medical Center has the ability to do centralization. We can do currently in the last 9 months, we've done 3,000 patient specimens. We have the capability to do about 3 or 4 times that now. And the reason is we're able to do that is that we do a lot of other based testing. Actually, our claim to fame is thyroid testing. We do a ton of thyroid molecular testing. We actually did in the last 5 years, we've done 100,000 patients with thyroid testing. The same architecture that built Pancreaseq helped with thyroid-based testing. We can easily accommodate more Pancreaseqs. And I have my heart is with pancreas. Obviously, I love thyroid in general as well, and I'm happy they worked with thyroid. And we're doing other things, but I really want to see Pancreaseq take off and pancreatic cyst testing take off, and this being a way that we can actually help improve patient care.
Finally, let me play the role of reviewer number 2. So every time you come out with a nice project on IPMN, I always get the same comment, and from an acceptance becomes a major revision. What is your view, like very synthetic, on concomitant PDAC?
Oh, that's a good question because I get that
Well,
too.
I'm now figuring out the perfect testing on the cyst, and now you can advise to even like let's say, no, I don't want to say stop follow-up, but at least, to have longer intervals and then concomitant PDAC comes out. Any way to somehow detect, of course, probably not, but what is your view on that?
So I think that, we're going to be doing, I think the ideal aspects will be not only that will we do an FNA, and, like, let's say you have a patient with 4 cysts. Are you going to FNA all 4 cysts for Pancreaseq? That's not going to happen. I think that eventually we're going to get to the point where we can do duodenal juice testing, and we're getting there. We already started doing some testing on that. We need to up the sensitivity of Pancreaseq. That's one aspect. And my thought process on that is that we take the largest cyst, we do duodenal juice testing, and those are the types of assays having dual-based testing to help with eventually screening the pancreas itself. It's not going to be perfect. Again, no perfect assay overall. Another aspect of Pancreaseq that I foresee in the future is concurrent germline testing. Pancreaseq actually doesn't do germline testing. There's another test that we do germline testing on top of somatic testing that we can actually infer germline alterations just taking a specific fluid. And so, yes, that will also be the case where we can identify high-risk cohorts because they didn't even know that they were a high-risk cohort if they have a BRCA alteration. And you'll be able to identify that with Pancreaseq, which will then help modify surveillance as well. And so I think that's where we're going at now. There's a lot of things that need to be done. We talk about Pancreaseq being 75 genes. Eventually we're going to get to the point where we're doing whole exome, whole genome testing, and we're going to have the same price. I can already tell you we're already working on the foundational model of exome sequencing. It's just that we're not at the depth or sensitivity we need to be at. But you give us 5 more years, we'll be there. So we'll be doing a lot in a very short amount of time, in my opinion.
We can't wait to hear more. Aatur, really, it has been fantastic. I might be biased, but I love the topic and your presentation, and also I would say your philosophy was really outstanding and mind-opening. So I thank you again so much for your valuable time. Cannot wait to meet you in person.
Yeah.
And I would like just to wish everyone, for the upcoming festivities, some nice time with your beloved and your friends and your families. And I'll see you next year on this virtual event. Thank you so much, everyone who came virtually here, and see you next time.
Thank you.
Bye-bye.
Happy holidays.